Welcome to the ASRS Oral History of Retina series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance.
Through these discussions, we will fill in gaps in our understanding of the evolution of the science and practice of retina. And it's our hope that these discussions will serve as the illuminating element in the larger mosaic of the history of retina.
Welcome. I'm Dr. Timothy Murray for the American Society of Retina Specialists. It's my pleasure to continue our series of our leaders and legends in retina. I would like to welcome Dr. Harry Flynn Jr., who's going to join us today. Dr. Flynn is the J. Donald M. Gass Distinguished Chair of Ophthalmology at the University of Miami School of Medicine and a professor of ophthalmology at the Bascom Palmer Eye Institute. He is an internationally renowned scientist and writer, as well as a passionate educator and mentor, whose 44-year-plus career spans a truly remarkable period of evolutionary growth in our field that we will hear about today. Dr. Flynn has authored or co-authored more than 600 peer-reviewed publications and 120 book chapters. He has also edited or co-edited 8 books on vitreoretinal diseases, surgeries, and therapies, and continues to serve on the editorial boards of several notable journals. He is a past president of the Vitreous Society, now the ASRS, as well as the Retina Society and the Miami Ophthalmologic Society. And, as you might expect, he has received numerous honors over the course of his illustrious career. Among them, the Gertrude D. Pyron Award, the American Academy of Ophthalmology Lifetime Achievement Honor, and the Herman Wacker Prize from the Club Jules Gonan, along with the J. Donald M. Gass Award Lecture. Dr. Flynn, welcome.
Thanks for the privilege of being part of this program.
Can you tell me what really drew you to medicine in the first place?
I was always interested in medicine, even in high school. They had seminars for students, and I always attended when a physician came and told us how to get into medical school, the courses to take in math and science. And so I did that in high school with the long-range goal of going to medical school.
And which medical school did you attend, and what drew you there?
I went to the University of Virginia, which is in Charlottesville, Virginia. And I went there for a number of reasons. It was a good school with a great reputation.
And where did you go for medical school, and what drove you into medicine and then into ophthalmology?
I, first of all, went through a physical exam as a first-year medical student, and I had an eye examination. And the ophthalmologist that examined me said, you would be perfect for contact lenses. I said, I really never thought about that. So about a week later, I went down and got contact lenses, and I said, wow, this is great. I can see so much better than I could with glasses. So that drove my interest in ophthalmology.
And then how did the ophthalmology residency work for you? There really wasn't a match for residency and fellowship at that time, correct?
No, there was not. This was a matter of the chairman and the existing residents, who were primarily the first-year residents, picking a medical student, fourth-year person, that they felt they could work with and had a potential for being a good colleague.
And where did you go for your residency, and what year did that start for you?
My residency began in 1972, and I stayed at the University of Virginia for residency. The key element in my career was my internship. I chose to go to San Francisco for my internship, for a medical surgical internship. But the reason I chose California Pacific Medical Center was they had a 2-month elective in ophthalmology. So I had the opportunity during my internship to watch many types of surgical procedures. And in particular, I had the opportunity to watch Wayne Fung, Gil Cleasby, and others doing vitrectomy, this new procedure that had first come about, first published in 1971. And so Wayne took me under his wing, and I watched him do surgery and said, wow, that's what I want to do.
So
Yes.
you go back for your fellowship with Wayne, and you're in San Francisco during the whole kit and caboodle of that, right?
Yes.
So can you tell us a little bit what fellowship was like for you?
Fellowship was a very exciting time. We had 3 fellows in the department. A couple of the other fellows had other interests and eventually did not stay the full year. But what that did for me was let me do 6 or 8 cases twice a week, and that was fantastic. So I loved being in the operating room, and I loved the interaction with patients. So this was a terrific time for me, the fellowship.
Tell me about that first day at Bascom Palmer. How does that go?
Well, I walked in the door only knowing a handful of people. I knew John Clarkson, George Blankenship, Dr. Norton. I had interviewed there and been out to dinner with Victor Curtin and a number of the other senior leadership people. And it turned out there was another new faculty member coming on board at the same day, September 18th, 1978, and that was Gary Abrams. So I walked around and found him, and I shook his hand and sat down and talked, and Gary and I became good friends over the years and right away, and of course the rest of the story is known.
What was it like starting at Bascom Palmer with you and Dr. Abrams and that team? What an amazing group of retina specialists all in one place.
Yes, it was truly amazing. We had the legacy of Robert Mockemer, who came as a fellow in 1966. And after his fellowship, he stayed on the faculty at the Veterans Hospital and became world-renowned with his vitrectomy innovations and courses that he put on. Also, Dwayne Fuller, who was head of me, was on the faculty for a number of years, but Dr. Mockemer left in January of 1978 to become chairman at Duke. Dr. Fuller left to join a group in Dallas in private practice. So they were, relatively speaking, 2 retina people down when Gary and I arrived. So there were a lot of cases, and I had the fortune of inheriting many of those cases at the start. But also, the American Academy of Ophthalmology was in September of 1978, and everybody left to go to the academy except me. And I said, wow, this is great. I can do 8 cases this week. So that was the story. I really just jumped right into the fire.
That was also a huge time of change in technology and our understanding of retina. Even though Dr. Mockemer had set the stage for us, things changed really rapidly. So can you tell me what that was like for you and what your involvement was through that early stage?
Yes, so when I was a fellow, there were a number of different instruments. There was the VIS-10, which was a large vitrectomy instrument. It required a full function probe with infusion, light, and cutting all in one instrument. It required a 3.3 millimeter sclerotomy. And people in San Francisco had abandoned that technique. In 1974, Connor O'Malley developed the Occutome. And this instrumentation was popularized by Steve Charles, and I enjoyed using it myself. So the Occutome was already at Bascom Palmer, but no one was using it. So Gary Abrams and I said, let's dust this equipment off. Let's start using it today. And so I used only the Occutome, and many people said, well, you know, Dr. Mockemer says that you should be using this. And I said, well, that's fine, but I'm trained in California, and I like the small gauge instrument, which at that time was 20 gauge and 3-port approach.
What drove you to start writing and being sort of academically focused with your research?
When I was a fellow, I put together a number of abstracts and presented them at relatively small meetings. But my first publications didn't occur until I got to Bascom Palmer.
So you come to Bascom Palmer with no publications at all.
0.00.
So there's hope for the rest of us. Is that what you're saying? Tell me a little bit about what it's like to have written as much as you have, and what continues to drive you to write. Because I find for some of the younger specialists, the retina specialists and surgeons, that they're not always as keen to write early. And I think that that's one of the things that they do benefit from when they do participate.
Well, I think the key element is balance, because some people in academic medicine are overly focused on RVUs, and others are focused too much on laboratory research. And my balance is using clinical care, clinical outcomes. So that's important, and I enjoy that balance between collecting RVUs on one hand to justify my salary, and the other part is the academic part. I don't have a laboratory where I'm doing basic science research, but my research is clinical outcomes. And so I work with the residents and fellows to achieve that.
So I love that. But speaking of salary, because I think that most people don't realize that that's not whatever has driven you, can you take us back to when you were recruited by Dr. Norton and tell me a little bit about what compensation was like then?
Yes, so in 1978 when I started, I had an offer letter. It included that he would pay my way to move to Miami, that he would provide support through secretarial and other functions. And my salary would be $50,000 the first year, with an opportunity for a bonus of $5,000.
You were raking it in.
I was happy with that. I had no problem. I did not, in fact, I said, Dr. Norton, if you give me a job, I'll paint the walls and scrub the floors.
So you're writing, you're operating, but you're really recognized also as a phenomenal teacher. So can you tell us what teaching has been like for you? It seems like you started teaching even in your internship residency.
Yes. Well, I enjoy teaching. I enjoy working with the fellows and residents, and they are hungry and eager to write papers and do retrospective chart reviews. And there was a remarkable lack of outcomes data. So outcomes on endophthalmitis treatment, outcomes of vitrectomy for endophthalmitis, trauma, diabetic vitrectomies, all of these things were important. And so I would spend many Friday evenings doing a vitrectomy for endophthalmitis, which was fine. And I look at endophthalmitis like a baseball game where the bases are loaded and you're the relief pitcher that comes in. It's up to you to save that game or save that patient's vision, and everybody expects you to fail, but you have the opportunity to really shine and save that patient's vision. So to me, it's a challenge, and I really enjoyed those cases.
So Dr. Flynn, what was it like working with Dr. Norton?
Dr. Norton was a great leader, but he was really a father-like figure to all of us on the faculty. He described himself as the caretaker for plants. He said, I pick the plants, I nurture them, and then I just sit back and watch them grow.
He was a lot like you in some ways, Harry, that he would wander and talk to everybody. He would touch base with the nurses and the clerks and the technicians and his physicians. And you seem to have done that also. Can you tell me a little bit about leading by walking around?
Oh, yes. So Dr. Norton knew everybody at the check-in desk, the security people, by first name. So he would go and say, hi, so-and-so, how are you doing today? How's the family? And that created a tremendous loyalty and feeling that you're part of a team. And I think that's the key to the success of Bascom Palmer. Not of ego flaunting, but really of a team effort.
What an amazing man. So of course, when I started, I was the last person that Dr. Norton hired. So it really is sort of a tight world. But when you started, you had Dr. Norton with you, but probably some of the most amazing people with Dr. Norton that played a role in founding Bascom Palmer. So what are your memories for people that the younger generation may not know, like Dr. Gass, for example?
So Dr. Gass came in 1963, and Dr. Norton came in 1958, and Dr. Curtin in 1959. Dr. Gass was always composed, respectful, and academic. So he demanded academic organization of the fellows, but he ran a fluorescein angiography course every Tuesday evening, and that was the best course ever. Most of us would cling to every word that he said because it was so humble and correct. He didn't exaggerate. If he didn't know the answer, he would say, I don't know, but then he would say, probably in another 6 months or a year, this is going to happen, and ultimately the diagnosis will be so-and-so. So we all respected Dr. Gass.
I always think of you first as a surgeon, as we've said, but you brought and introduced so many new technologies into the operating room and into the clinic. Could you tell us a little bit about how important that's been and how you were able to accomplish that?
I think not being afraid to try new technology. Some people are always reluctant to jump in. As I mentioned with the Occutome, Gary Abrams and I were the only two people using the Occutome back in the late 1970s. And then roughly 1983, the endo laser came out, and Dr. Norton said, well, can't you just laser them the next day or the next week? And I said, no, Dr. Norton, you don't realize we're there, these patients are bleeding, or they have a tear that we need to treat, and you can't reach it with cryopexy. You need to treat it directly with endo laser. So Mark Blumenkrantz and I banded together. Mark became part of the faculty and said, Dr. Norton, we have to have this. And fortunately, Dr. Norton bought it for us for the operating room. And then there are a number of other techniques. As you know, the cannulated extrusion needle with 20-gauge surgery was developed by Mark Blumenkrantz and me in roughly 1987. This was before PFO was readily available, and it allowed us to do internal drainage of subretinal fluid with an extendable soft tip needle. And occasionally I still use it now on certain cases that I need to use a quick procedure. I often like 5,000 silicone oil in these cases. Another interesting story that I didn't mention was in 1979, I went to the Wimbledon tennis tournament. And while I was there, I took another week off and went to Cambridge, and I watched John Scott do vitrectomy surgery using an indirect ophthalmoscope and using silicone oil. I was fascinated with using silicone oil because this provided a long-term tamponade beyond what was available. And so many of us became obsessed with getting silicone oil. There was no silicone oil in the United States. So with the help of various colleagues, I was able to bring some silicone oil in my suitcase, and then I would have it purified and checked for sterility by Jean-Marie Parel, and we used it. And so this was way before it was FDA approved.
And then what about technology? So you go from vis to Occutome when you start, but we've come so far from what we thought was small gauge surgery back then to what is small gauge surgery you're doing now. So could you take us through some of that surgical technology?
Yes. So in 2004 and 5, small gauge surgery started. I give credit to Jean Dewan and his colleagues that really started moving forward with this. I thought it was fantastic. I said, this is terrific. You don't need to suture these sclerotomies. It's quick. You get in and out, do what you have to do. especially for endophthalmitis cases. I tell the fellows that an endophthalmitis vitrectomy should be maximum of 15 minutes. You should not futz around with vitreous-based shaving. You should not try to make sure the hyaloid is loosened. You just clean out the opacities and you get out. Put your antibiotics in. So we had a meeting at Nantucket Retina in 2005, and we had key leaders at that meeting. We went around the room and took a vote on whether this was going to survive and move ahead. And there were a couple of prominent people who said, oh, this is a passing fancy, just cannot survive. And I raised my hand and I said, have you ever tried it? And the answer by both of the people was, no, I haven't tried it. I said, try it, you'll like it.
That's true, so true.
And I think after that meeting, more and more people really became really happy with a small gauge 25 gauge, and then Klaus Eckhard introduced 23 gauge, and we were even happier because it provided a little more sturdy instruments and let us do everything. And then we provided all the ancillary tools, the forceps, the PICS, the endolaser, all of those things came along with small gauge surgery prototypes.
And having Jean-Marie Parel in the laboratory, who had worked with Dr. Mockemer, I've always thought was a huge asset to both you and I early on, and continues to be. So what was that like, having someone of Jean-Marie's caliber there for instrument design and development?
It was fantastic. Even today, I go over to visit with Jean-Marie and I ask him about instruments and about his approach to things. So Jean-Marie is a big part of our history, working with Robert Mockemer and designing and implementing vitrectomy. Helmut Buechner was also very important. Helmut actually built the first vitrectomy out of model airplane parts. He soldered it together with infusion and cutting and suction and a little ever-ready battery inside of a syringe, and hooked it up electronically so it swirled around to cut vitreous. And I think everybody's seen the prototype of that instrument. So Helmut Buechner was a key player, as well as Robert Mockemer, and Jean-Marie was in the background helping as well.
So your patients were blessed, your residents and fellows were blessed, but you also broadened your reach through your meeting and societal participation, and you played a major role in the Vitreous Society, which is, of course, now the ASRS. Could you talk to us a little bit about what society was like at the time and what drove you to be so involved?
There were a number of people coming out of fellowship that were good friends, and those include Alan Verne, Paul Tornamby, Sandy Grizzard, and many others, Andy Packer, that were young vitreoretinal surgeons. And we got together about 1982 in San Francisco at the Academy. We were having dinner together, and Alan brought up the issue of, we didn't have an organization that was representative of the common man being right out of fellowship, maybe in private practice, but maybe not a candidate for the Retina Society or the Macula Society. We needed a representative organization. And so we went around the table and everybody said, I'll never get in these societies, so let's form our own society. The first two meetings were in Palm Springs, and they had an attendance of 25 or fewer people. But then the third meeting in 1985 was in Orlando. At that meeting, we had somewhere in the range of 50 to 75 people, and every person presented either a small series or interesting case, and there was plenty of time for discussion. The meeting was set up so it was morning only. The afternoon was free to be with your families, to go to see Disney World or do other things besides ophthalmology. The early meetings did not allow exhibitors to set up a booth. But they did allow representatives to come to the meetings, sit in the audience, and discuss things at lunch or breakfast or breaks with the members, and that was a fantastic setting. The early bylaws of the Vitreous Society included the need for 2 publications and 2 letters of recommendation, and to pass the American Board of Ophthalmology. We shortly thereafter changed those rules. We did away with the requirement for publication. We had international meeting members who obviously couldn't pass the American Board of Ophthalmology, but we kind of made things more flexible. And the society grew and grew and grew, so that by 2007, it was over 3,000 people. And I don't know what the numbers are today, but it's a very large organization.
And I think you were also really good early about making sure that it was inclusive. So it wasn't just for people that couldn't get into the Retina or Macular Society. It really was going to be a broad society that incorporated academic specialists and people outside of academia.
Yes. So a lot of the nucleus of people in the early days were people around San Francisco, and those included the late Dr. Paul Tornamby. Paul was a medical student when I was an intern, so we met during that time and hit it off very well, and everybody knows Paul, what a great person he was. So Paul was a resident when I was a fellow, and our friendship continued. And Paul, of course, was an early president and also a very important person in the organization. Sandy Grizzard did his fellowship over at UCSF with George Hilton. And so Sandy and I also knew each other. And when I was going to Miami, he was going to Tampa, first at the medical school and later into private practice. So Sandy was also a really important person for the Vitreous Society and organizing meetings and planning the program, and a great friend of Roy, Allen, and Jerry. So this was an important group of people. And then we go down the line, of course, David Williams and his great book of the early days of the early years of the society, and Julia Haller. I first met Julia when she was a fellow in Baltimore. I went up for the Atlantic Coast Retina Club, which was being held at Wilmer, and that's where I met Julia the first time. And Julia is a great person, and I think her personality and hard work helped to really grow the organization. Julia pointed out an important mistake in the early Vitreous Society diploma. The diploma said the name of the individual is recognized for his contribution to the field of retina and outstanding clinical service. And Julia said, wait a minute here. And quickly that diploma got corrected. Julia has gone on to a terrific career and a prominent leader even now with the ASRS. And then going into Kirk Packo. Kirk was president a couple of years after my time as president, but Kirk was a key player in that San Francisco meeting, a combined meeting of the ASRS, or actually the Vitreous Society at that time. But Kirk had a vision for a larger organization, the ASRS, as opposed to a somewhat limited Vitreous Society. So I think together with Jean Dewan, Kirk Packo, and the founders, it was a transition into the new organization that had a greater impact on our field than the Vitreous Society alone.
Harry, you're going strong as when I first met you, 40 years into this. So what drives you to do this? And what do you tell that young doctor just looking at a 40-year career that's going to keep them engaged? We hear so much about burnout, but I don't see that in you, and I've never seen that in you.
I think that focusing on the patients, focusing on helping people, focusing on academic endeavors, trying to stay out of administration and bureaucracy. I feel quite blessed to have not been a chairman and have not been trying to be the king. I try to be part of a team rather than to be dictatorial. Having family support, my wife tolerates my long hours and working, and she knows I thoroughly enjoy it. So I will continue to work.
So I'm very excited about that, Harry. So I
Thank
think
you.
You have a lot left to give to your residents and fellows, your patients, and really to our field.
Thank you.
So thank you for being here with us today.
My great privilege. Thank you.